Hello, everyone, and welcome to today's webinar, Taking Ownership, Strategies to Bring Evidence into Clinical Practice with Professor Matthias Keller. Before we get started, I would like to go over a few items so you know how to participate in today's event. You've joined the presentation listening using your computer's speaker system by default. If you would prefer to join over the telephone, just select phone call in the audio pane and the dial-in information will be displayed. You will have the opportunity to submit text questions to today's presenter by typing the questions into the questions pane of the control panel. You may send in your questions at any time during the presentation. We will collect them and address them during the Q&A session at the end of his presentation. There is also a handout available. Please be sure to download this prior to the live event. Download it anytime you wish, actually. Just take a look at your panel, and towards the bottom, you'll see the handout section, and just click on those links. Today's webinar is being recorded and will be made available at Medila University, as well as Medila's Education for Lactation Professionals YouTube channel. I would now like to introduce Professor Matthias Keller. He is the director of the Children's Hospital Level 3 Passau in Germany and professor at the Technical University Munich. The hospital provides inpatient and outpatient care for children and adolescents, combining modern medicine with a desire to uphold established traditions. Professor Keller is a co-founder of the European Foundation of the Care of Newborn Infants, EFCNI, member of several scientific boards of neonatology, and president of the Society of Pediatrics in Southern Germany. In the year 2021, he received the Federal Cross of Merit in Germany for his engagement for newborns and their families. His current special interest in daily practice and research is hospital management and public health. Professor?
Good day, everybody. Thank you very much for this kind invitation. I'm very happy to be able to share some thoughts. How can we bring evidence into clinical practice? As mentioned, I'm a neonatologist. I'm working at the NICU, but also I'm heading the whole children's hospital. And what is very important, if you deal with managing a hospital, you have to have and you have to define a common goal. And here we are talking about the goal, and the goal is at the end breastfeeding, because we know, of course, that human milk, breast milk feeding is the best what we can do for the newborns. The challenge is that although we know that breastfeeding is so important, the breastfeeding rates are pretty low, especially in preterm born infants, which means prematurity is a high risk factor for non-breastfeeding. And this depends, of course, on the gestational age. It might be that you have also some similar data, which means between 24 and 31 weeks of gestation, we have lower rates of breastfeeding rate as the charts, as we have seen it in the late preterm infants, defined as 32 weeks to 36 weeks of gestation. So which means we do have low breastfeeding rates, and this is something which need to be changed. Also in term infants, it depends on the region where you live. We have just an average of breastfeeding rates of 70 to 80%, as that this depends a little bit on the social cultural context the family and the newborn is born. So the overall challenge is that if you look at the question, how can we get better in general, then we have the situation that we are in different units with different people, and this results in a huge variation of the quality of care and the output parameter. And I'm not talking here yes on breastfeeding rates, but this is the mortality, which is even more intriguing. So on the y-axis, you see the mortality rates, and each dot here represents one neonatal intensive care unit. And you see here there are small units with little amount of admissions, and we have very large units. However, you see that within large units, you do have a huge variation of mortality. but not only on mortality, but also on diseases like necrotizing enterocolitis, like retinopathy, like BBD, IVH. So which means all these units, they do have the same knowledge, they have to have the same target, they want to have less or low rate of baby dying, newborns dying, they want to have a low rate of necrotizing enterocolitis. However, there is this huge variation between the outcomes depending on the NICU the baby is born. And this is something what we have to talk about. And the question is, how can we bring the knowledge into standard of care in each individual NICU? And why is this so complex? The complexity is that we have, I'm very sorry, that we do have, sorry, I just have to bring that slide in front. So just a sec, do have this here. I'll be back. Okay, so sorry. What are the challenges? The challenges in this situation is that we have a complex patient population, which means NICU patients are complex patients. And on one hand, they differ from gestational age, they differ from the perinatal history, they have different conditions when they are born. But what is also important, and I will come back to that later, that they have a long patient journey until they get discharged. The second reason why we have these barriers in quality management in NICU is that we have this variability in practice. And within this variability of each individual, it adds that we have a high staff turnover, and that we have in the NICU overall a high staff number. And fourth, we have resource constraints. When we are discussing about how can we improve quality in our NICU, with, let's say, in breastfeeding rates, and then we have the discussion in our hospital, of course, yeah, but we don't have enough staff, we don't have the equipment, we don't have the space for breastfeeding for the mother, or there is a lack of pumps, whatever. There are a lot of reasons why things cannot be implemented. And what is also important is that we lack of data. I'm not sure how many units really know exactly at a given time point what are the breastfeeding rates, or what is the rate of human malnutrition at day 7 after birth, or what is the breastfeeding rate after discharge, 3 months after discharge. And this is challenging because it's effort necessary that you get this data. Additionally, we know that if it comes to breastfeeding, but overall also outcome for the newborn, that we know family-centered care is one key point of neonatal care. And also there we have some challenges in implementing this, because family-centered care is a matter of attitude of the staff members, and there we have huge variations between the NICUs in the degree of implementation of family-centered care. And last but not least, we have all these regulatory and accreditation requirements, so that we do not have only take care about the patients, but we have all these administrations behind, which sometimes are not really of benefit to the patient, but it needs to be done. And this is also time consuming. And there we have again the lack of resources. And then what is important is, of course, that the quality in the NICU is not only dependent on physicians, it's not only dependent on the nurses, it's not only dependent on lactation consultants, it's not only dependent on anyone. It's the whole team which is necessary, which has to be able to work together and to focus on the pathway of the family and of the patient. And of course, what we need is, and what is challenging in the neonatal unit is that we have this methodology. How can we continuously improve quality? So to do excellent neonatology is not that easy. And this is what I just wanted to highlight. We have different variables, and we will come back in that in more detail if it comes to breastfeeding. So, and the point is, the more difficult it is, and the more barriers there are, then you need a strategy to bring evidence into clinical practice. And I personally am very desperate sometimes, because if you look at these huge variations of mortality, you know, I think that sometimes we do have a lack of strategy to bring our knowledge to the patients. But this is actually our work. So we have to do and deliver the best care, and we have to think about how to deliver the best care and how to guarantee over time the best care. So what I'm talking about is, I will summarize now the challenges in quality managing as you focusing on human milk nutrition. I will introduce you to the concept of clinical care pathways. I will share our experience, how we did that, and the factors of success, and also some pitfalls, and show you some data. And then I will talk the quality challenge, so which means sometimes it's easier to achieve the challenge than to keep the quality than to keep it. And we will talk about there what are strategies to keep the quality in the unit. So with respect to the challenges, if it comes to breastfeeding, and what is very important, it's the team. And I'm sure that you fully agree to that. We had some situations where we were telling the family, you know, the human milk is so important to the preterm infant because it's protective against NEC. And there's just one single person at night, let's say the cleaning lady, and said, oh, you know, I was grown up with formula, so it doesn't really matter. And then suddenly the mother is completely confused. So we have this challenge that we have to have the same attitude and the same goal and the same knowledge of the team, which is also important. Second is that we have, if you look at newborns, we have the patient and we have the family in the center, but there's so many people around, like the lactation consultants, the obstetrics, the midwives, we have the neonatologists. So which means we do not have only different team members, which of nurses or midwives. We have all different disciplines, and all of these members of the different disciplines, they need to be aware of the importance of breastfeeding. And we do have a lot of interfaces, so which means we have to make clear who is responsible in the patient pathway for which process. And then we have this. This is the environment we often and frequently see in the NICU. And this is not an environment where the family feels comfortable. So which means one barrier is, of course, how can we create an environment where family integration is more acceptable, or how we can integrate the family more so that they feel that they have a kind of area where they really can pump milk in a setting where not a lot of people are staying in the room or passing by. And what is also important is that if you look at the neonatal intensive care medicine, that it's a long journey of the preterm born infant. And if you look at breastfeeding, we have the situation that actually prenatally the education of the mother needs to be started, and mentioning the importance of human milk nutrition to preterm infants and breastfeeding after discharge. And the challenge is that we have this long journey. We are talking about 2 months, 3 months in the neonatal care unit, and then after discharge. So we need to guarantee a continuum of care. Yeah, so we have interfaces within the teams, but we have this also long duration where the patient is at the NICU and the family. And the question is, how can we guarantee the continuum of care and the consistency of what we're doing with the patients and the family? And what is also important, that not one size fits all. So the needs of the family and of the patients is changing over time. So which means we need to deliver the solutions to the right family and to the right patient to the right time. So we cannot just implement one methodology prenatally and say, okay, this is now the standard for the next 3 months. no, we have to adopt what we offer to the patients with respect to human milk nutrition and breastfeeding, but also other support for the family and the patient. And what is also important is that I'm not sure how many lactation consultants are now listening here, but we have the challenge, of course, that the experts are not around all around the clock, but the problems they are occurring just when they are occurring. So we need to have a strategy that all staff members, the nurses, but also the physicians, that they have at least basic knowledge and basic skills to support the mother and educate the mother in terms of human milk nutrition and breastfeeding. And we have, and this is one study from California, we have often the lack of policies and procedures. So they were, in this study, they just looked whether and how many units did have policies in place for breastfeeding, and the rate was here just like 35%. So that's very low, given the importance of human milk nutrition. Human milk is, so to say, the gold for the preterm infant because of its benefits. So if it's something such of importance, then of course we need to have 100% of SOPs in place to guarantee human milk nutrition to the preterm born infant. And then what is important, that the mother is part of a cultural context. So we know from a German study that a major risk factor that the mother doesn't breastfeed is the mother-in-law or the grandma. So this is also important, that we have an understanding that the mother and the family, which we are focusing on in the NICU, that they are also part of a society, a part of a family. And so sometimes it's really necessary to involve also the grandmas and to think about educational materials for the large family, so to say. And then we have these challenges, and these were my 3 kids. Now I've got 4, that the mother, often they have also other kids. So we have to think about, if it comes to stressors to the mother, we do know that, you know, mothers of preterm born infants, they do suffer from peripartum depression. We have the challenge of parental bonding, but also that they have to worry about other kids at home. So the question is, how can we support the mother that they can, let's say, establish healthy bonding to the child and be relaxed to have milk production at the end. So you see, especially just looking at breastfeeding, then we have all these challenges, and then we didn't talk about money, infrastructure, and resources. And the overall question is, who's responsible for that? Who's responsible? We have said there are different disciplines: the gynecologists, the obstetricians, we have the neonatologists, we have the nurses, we have the lactation consultants. And the question is, who at the end is responsible for excellent quality of care, which means, let's say, a rate of 85% of breastfeeding rate at discharge. And sometimes this is not yet fixed in the NICU. But this is important, because if you are not the owner of the process, you don't feel responsible. You just feel as a little, no important part of a puzzle. But everyone in this patient care pathway is important, and everyone needs to take ownership about this process. He is responsible. And sometimes we really recognize that it's not clear who is responsible for the specific step in a given process. And this is what I call ownership. So to summarize, what are the challenges in breastfeeding in NICU? We have, of course, the physiological immaturity. It's clear, you know, the newborn, the preterm infant, they don't have yet suction reflex. They can't go to the breast directly. And sometimes some units, we do not have yet skin-to-skin care, which is important because of the immature of the preterm-born infants. Then we have the medical complexity, as I said before. We have the separation from the mother. It's very challenging. There are a lot of studies that if you have a separation from the mother 2 to 4 hours after birth, where the mother can't see the preterm-born infants, that you have an influence on maternal-infant bonding, and this has also an influence on milk production of the mother. We have the breastfeeding barriers, such maternal stress, anxiety, pain, and fatigue, and all the things I mentioned already. We have the NICU environment, we have the provider acknowledgement support, the parental support, and of course, I didn't talk about that too much, but the question is, how do we guarantee the continuum of care after discharge? Is there a support for the mother? Because it isn't different setting whether you are in the NICU, where every time somebody is there, who you can ask, or whether you're at home, what are the concepts after discharge? And of course, I mentioned that the cultural and socioeconomic factors. So again, the challenges are enormous, and of course you could say, you know, there are too much challenges to just do nothing. But this is not really a solution because, as said, with respect to human work, it's the goal of neonatology. So we need to do something about it. So what is important is that we have to address these challenges, and you cannot just address one challenge. I highlighted this. You need to address all the challenges, and for this you need an approach which is multifactorial, multifaceted, which means you need, of course, leadership support, staff engagement, you need data-driven quality improvement initiatives, you need the interdisciplinary and multidisciplinary collaboration, and of course you need a commitment to patients and their care. So these are nice words, how to do it in practice. What I found is that the concept of clinical care pathways is really one of the best methodologies to face and to go over these barriers and challenges. And clinical care pathways are defined as structured multidisciplinary plans that outline the sequence of interventions and treatments for patients with a particular condition or undergoing a specific procedure. And I highlighted to you that we have these 3 months of clinical care pathway, and we have 3 months of different needs of the family and the patient. So neonatology is one of the best examples why clinical care pathways are so important, because they are designed to standardize the care of delivery, improve efficiency, and to enhance patient outcomes by evidence-based practice. And this is particularly of importance the longer the patient pathway and the patient journey is. They improve patient care through consistent management. So these are all published data. They maximize the efficient use of resources. They reduce the length of stay of hospital. I will show you some data. They reduce unnecessary variations, and they support clinical effectiveness. And this is just a recent publication. It's completely busy, but I just wanted to highlight you this reference if you're interested in. Because what is very important, and I like it very much, is if you see here the antecedents and the attributes. What is important, and we mentioned that you need a commitment of the leadership, that you want to have these clinical care pathways on the one hand. But what is also important is that if you implement such a clinical care pathway, then you have to have a strategy of change management and a change management team. And then you have the attributes, which I highlighted already, with all the consequences. What is the result of clinical care pathways? So if you're interested, here's the references. But I think it's very important to think about that you have to have a strategy to implement clinical care pathways. And this has a lot of things to do with change management. So I'm talking now about the practical implementation, how we did it here. As said, what is very important from the very beginning is that the whole team has a vision, has a goal, and has a consensus. What is excellent neonatal care? And I suggest here that excellent neonatal care is has 3 different columns. It's the medical care, it's the developmental care, mainly from nurses, but also physicians, and it's family integrated care. And only if we integrate all these 3 columns, then we can provide excellent neonatal care. So let's say family integrated care is one very good example how to increase breastfeeding rates. And if we have enough human milk, this has direct influence on maternal care. The more human milk we have from the own mother, the less the rate of necrotizing enterocolitis, less rate of PPED, better growth of the child. So we have an interaction. Family integrated care and breastfeeding is not per se one column, but interferes with medical care and contributes at the end to excellent neonatal care. And this does mean grow a development of the child with high quality of life after discharge. But how to do that? The first step, what we've done is, as we developed our concept of the clinical care pathways, that we have to think about what and who is necessary for good outcome. And you know this already. This is now the clinical care pathway of the newborn, of the preterm. And we have highlighted here now all the different disciplines, depending on the stage. And this made it possible to systematically approach what they have to do at a given stage. We focus here now on breastfeeding, but we did this also for medical treatments like surfactant application or closing duct or others. But now we are focusing on breastfeeding rate. And then if you look at the different steps, which are important, and this is just an extract, we have important steps if it comes to breastfeeding rate at discharge. This is the initiation of lactation, the maintenance of lactation, then the initiation of breastfeeding. This is also another milestone, which is very difficult sometimes to the mother. So I would be curious to hear about your experience. Then the challenge of continuation of breastfeeding, and then after discharge, the maintenance of breastfeeding. So these are the milestones as we have defined it. Perhaps you can add others, but these are the milestones of human milk nutrition and breastfeeding in the NICU in our eyes. And what happened then is that we asked the team, okay, these are the milestones, and let's set up, please, standard operating procedures, data for document concept with the goals. What do you want to achieve? Let's say we want to achieve that latest after 2 hours, the mother has skin-to-skin contact with the preterm infant. This is a defined goal. They had to provide the background, the references, and the indicators, which means did we achieve? So we wanted to have 80% of the mothers of preterm born infants, they see the child after 2 hours, or we are pumping already prenatally or directly after birth, whatever. They had to set up the standard operating procedures and checklists and the documentation, information, material for the mother, etc. And if it comes now to the breast milk pathway, as we call it, and again, this is something which we have developed, and you can, of course, add. This is not final, you know. It's also important, and we come back to that. Clinical care pathways and SOPs are viable documents. It's not static. But I just have simplified it for educational reasons. It starts the breast milk pathway by identification of the mother prenatally. That's not that simple, because you need to have a strategy and you have to have an SOP when the lactation consultants or the doctors of the neonatology get informed that the mother at risk, which means the mother will get preterm born infants, the mother at risk, that they is admitted to the gynecology apartment so that somebody can pass by and provide already some information what will happen with the baby, and in case of breastfeeding, how important is human milk nutrition. So which means you have to first step the identification, and we have to motivate the mother to educate, it's a better term. Then we involve lactation consultants. Then the one possible next step is early first to skin contact in the delivery room. then the first pumping colostrum already in the delivery room, then again motivation enhancement, positive reinforcement, and I won't go through each step because I just wanted to highlight that if you dissect the patient journeys from these milestones, and then the milestones get dissected in different steps within the process, which are necessary at the end to get human milk in the first step, an early stage, and then at breastfeeding as discharge. And this is something which needs to develop in your unit. And what is important is, and this is what I highlighted before, is the concept of taking ownership. While doing this clinical care pathway, the breast milk pathway, we have to define the SOP, who is responsible for which step in this process. This is the key. What we have established is that we have implemented a case and care management team. The case and care management team, this is this lady here. This lady gets in touch with the family already prenatally and makes the contact after discharge. So every family admitted with at risk, they get in contact with the case and care manager. And the case and care manager, they guarantee the continuum of care, which I was talking about before. So this is a kind of unique, but in our eyes, what we see, because we have this huge variation, we have night shifts, we have fluctuation in NICU staff members, and these ladies, which are mainly trained nurses, they provide a continuum of care for the family. They get in touch with the family, they ask the needs of the families, and they recruit team members to deliver solutions according to the needs of the patients. So what is important is, again, I mentioned already, the clear definition of process owner. What are the results? And I would like to show you some of our results when we have implemented it. This concept was implemented 2014, so which means 10 years ago already. So we have 10 years experience in that. And we established it, developed in the year 2012, 2013, and implemented 2014. And we were lucky because we could now match our cohort with the overall German cohort and make matched pairs, it's called, so that we could compare our results with the German average of preterm care. So these were over 20,000 babies, were the control group, and we had our intervention groups. And there are a lot of data here, and I won't go into detail, but I want to highlight the very low numbers of diseases. And I'm not sure whether and to which extent you know your outcome data, but it's important to know the data. We had with NEC in the intervention group before implementation of this concept and NEC rate from 2.7%, and afterwards 0.6%, whereas the control group had 2%. So which means we had a 60% reduction in NEC. We had a very low rate of late onset sepsis. We had a very low rate of BBD. You see in our intervention group that we didn't have any BBD in these very tiny babies in a time period of 3 years. When it comes to human milk nutrition, then as you can see here, then we had very rapidly now already at day 3 of life, we have pure human mother, let's say human milk nutrition from own mother of 86% of the preterm babies. So which means at day 3 already 86% of the preterm babies are fed by their own human, by their own mother human milk completely. If you look at the breastfeeding rate as discharge, we had very low numbers when we implemented the program. So which means in the very tiny babies, less than 28 weeks of gestation, we had only 44% of breastfeeding rate at discharge. And after the program, we had 75%. And if you look at the bigger babies, let's say the babies above 28 weeks of gestation, we have an increase from 61% to 91% breastfeeding rate at discharge. What were factors of success and pitfalls? What is very important is to understand the purpose and the benefits. The people in working with us, they are very, very motivated, but you need to understand the purpose and the benefits, why you need this change management and why you see the benefit of the clinical care pathways. And what is important is that you need to be aware that every person, even the cleaning staff, is important in this process, and you have to recognize their role in improving efficiency and enhancing patient outcomes. What you also have to have is engaged stakeholders, which means you have to have a team of healthcare providers, but administrators, but also engage family patients and in your unit, because they can also give you some ideas how to improve this pathway. So we did it from the very beginning, that we have an advisory board of parents involved in setting up this clinical care pathways. How can we improve breastfeeding? What do you need to get better pumping in the unit? What support do you need? We were talking about leadership support already. What was also one very factor of success was this work that we overcome the barrier. So neonatologists talk to nurses, talk to lactation consultants, and they had to discuss the clinical care pathway. And by doing this, it's not only that we exchange knowledge and educated each other, but we also formed a team. So this is very important. And then what was important is that it was not, you know, when I came to the unit 12 years ago, I had this idea to implement a clinical care pathway. But it's not that, and this is one major pitfall, that you have this idea and you want to do it, you hear the presentation of Professor Keller and you come and now you immediately implement it. But that's not very good. You should really tailor care pathways to the specific needs and your resources. You know, we have a very famous also unit for family integrated care, and if you sometimes the people get frustrated because they say, okay, we cannot implement it in our unit. But that's not the point. If you engage the people and everyone takes ownership about their importance in this process of breastfeeding, here is an example, then you achieve really better quality and care of the newborn. What is important is training education. It's the key. The people need to have knowledge. You need to have monitoring and feedback mechanisms. I will come back to that later. But you know, one major pitfall in leadership, if you're heading in hospital or in NICU, or if you are the process owner of a pathway, you think, and it was my pitfall, I become the head of the department and I said, you know, okay, now we have the SOP and now we do this SOP. And then I said, okay, it's like a train, it's, you know, it's on the railway and then the train will run. But it doesn't run automatically. So we have to have methods that the train is running, but the train is running into the right direction. Because if you do not monitor and if you do not provide feedback mechanisms, and if you do not provide every day that you check for quality, then you will lose quality over time, and we will come back to that again. So which means one hand is that you need to have measures monitoring what you are doing. So which means if you want to achieve, let's say, this example that the preterm child needs to be on the belly of the mother 2 hours after birth, then you have to record it, because you have huge staff members and suddenly you have 3 hours, and then, oh, it doesn't matter, you know, I had to have a phone call and then afterwards it's 4 hours and nobody notices. And then sometimes you have a change of behavior again, and then it takes more efforts to bring it back than if you would monitor it and you see it and you detect the deviation very, very early. And of course, you need continuous quality improvements. You have to implement new methods, new technologies. Now we have of course, digitalization, where you can use different tools out of educational material. And you have therefore to evaluate and updating your pathways. And what is important, you have to celebrate success. You know, the team, as my experience, all people who are working with families and newborns, they are highly motivated, they are nice people in general, and they do their best, but sometimes they forget it. And then you have to say, okay, please focus what we have agreed in the standards. But they are nice people and they do a great job, and you have to celebrate the success. This is also very important. And this slide shows you the question and reminds us, how do you navigate? If you look at quality data management in the hospital, you know, we have also kind of our controlling, and we provide us with the outcome data. And at the very beginning, I got the outcome data half a year later. And this would be like we are driving a car by looking in the mirror in the back. Because what happened, but I need to know what is actually going on to navigate. And this is one of the major challenges in the clinical setting, that we have to have a clear perspective navigating. And this means we need actual data in our unit. What is the current quality of care in our unit? And this is also questions that you have to ask in your unit. Who is responsible for quality management in your unit? And here I'll tell you just a small story. When I came to the hospital I'm heading now 12 years ago, we had so-called quality manager dedicated in each ward, and for each profession. And then the guy from the administration comes, Professor Keller, you are now the head of the department, and you need to have, and you have to nominate a medical doctor who is responsible for quality. And then I looked at him and said, well, you know, at the end, it's me, because this is my job. I'm responsible for the patients, so which means I'm responsible for the quality. And when I'm responsible for the quality, I'm responsible for the quality management. And when I have now new employees or new colleagues, and they get employed and they say, well, I want to set up a new process or a new medical field, and then it's clear that they are responsible for the quality. So quality management cannot be delegated to an administration or to somebody. Quality management is each individual on the unit. It's also the cleaning lady. She does nothing else in quality management because she ensures that the unit is clean and that is disinfected and we do not have any bad bacteria in the unit. So which means we need to be aware that taking ownership of each process is nothing else than quality management. And then you can ask which tools you use for quality improvement management. Yeah. What is the concept to detect drop in quality in your unit? So let's say the cleaning lady, it's obvious. You go through the unit and then it's dirty, and you say, okay, you know, it's dirty, you know, you have a drop in quality. But what about NEC? It is so easy to detect when you have a drop in quality in the babies. What is the, you know, there's so many, how to detect it? And then what strategies are implemented in your unit to keep the quality? What is your thought? What can I do to keep the quality in my field of responsibility? And this is a very nice work. It's a piece in German, but it's from a very famous professor. And this is one major pitfall. You have a result of change and you do planning, classical PDCA cycling, and you make a plan and then you implement it, and then you have a high quality, high change, and then you are proud because you have this quality. And then you go away and you make other things, and then you come back after a time, and suddenly the quality is dropping. And that's the reality. Mr. Denham, who developed this PDCA cycle, wrote a book, and he said, you know, I'm very proud of the PDCA cycle, but the most frustrating thing is that I couldn't really find a methodology to keep the quality. And that's true. Because then this is only one effect. if you have, let's say, a high fluctuation, you have a loss of cumulative knowledge, what we call in a unit. And just by adding new members, you lose quality because you have the loss of cumulative knowledge of the NICU. So which means we have to have strategies and to think about what can we do to keep the quality. So first is we have to ask, how do we measure this drop? It's really too late if you get the outcome data 3 months to 6 months later. So it's too late. So you need early indicators. Early indicators, let's say breastfeeding rates. If you recognize after 6 months that your breastfeeding rate is at discharge, it has dropped from 80% to 50%. And then you have to go back and find the reason. And it turns out that whatever in a staff member has changed and she's just for formula. And then, of course, it's too late, and in half a year, the babies were not well treated. So which means you have to have very early indicators. And then you have to have strategies. And let's say one example, what we have implemented with the new team members, but also with the senior team members, they go every year to an educational program where we remember them and also develop the clinical care pathway further. So we remind them, what we agreed to do on the clinical care pathways, whether we detect deviations. We do videos of how the nurses care for the babies. We have recordings and educational programs. So, which means for each step which is important to you, you need to have a kind of concept how to guarantee and how to bring and motivate to people to adhere to the clinical pathway, that you have a high consistency of the delivery of care. So challenges and barriers in quality management, there were a lot, and I ended with data management, documentation, and continuous quality improvement. But and this is the good news, also we were talking about all these challenges. At the end, it's possible. And I think I'm very grateful that I'm a neonatologist, because this is one of the wonderful parts of medicine I could imagine to work. And with this very families, I would like to thank you for your attention. And I'm open for the questions which were posted in the chats. And yeah, I hope and I wish you all the best for your work in the NICU for our patients.
Wonderful, Professor Keller. And if you need to grab something to drink real quick, go ahead, please.
I'm very sorry, I have a little cold, so.
Absolutely fine. Thank you so much for that presentation. We're now going to begin answering the questions submitted during today's presentation. Remember, you can still submit questions through the questions pane in your control attendee panel. The first question is, we have donor milk available for our NICU babies, but oftentimes NICU nurses don't tell the parents about it, and babies are supplemented with formula. How do other facilities deal with staff encouragement of offering donor milk over formula?
I can tell you how we did that. In fact, what we did is that one is of course education. So if this is done by the nurses, it's an educational issue. They need to be aware about the benefits of human milk nutrition on one hand. So I think this is the first responsibility, that they need to know what is good for the patients. But what we have also implemented is that we have implemented information material for the parents. And I'm not sure whether this is the case in your part where you are working, but if we provide drugs with significant side effects, we have to tell that the parents. And we have designed an information sheet where the parents need to sign that they want to have the baby fed by formula, because we do see formula nutrition as one risk factor for adverse outcome in preterm infants. So which means we just switched it, so to say. So which means for us, standard of care is donor milk or own milk. So which means we also have a human milk bank. And the family needs to sign really a piece of paper that they want to have formula.
Perfect, thank you. Bear with me just a second. I'm working on the next question. If human milk, I wanted to make sure I didn't read this. If human milk consumption is increased, infant weight gain is not as rapid. How does that affect the drive to get babies discharged? Would exclusive human milk delay discharge, or can discharge policies be safely modified?
This is a very important question, and this is also one factor what we have identified. I just want to summarize a little bit the question whether I understood correctly, but the phenomenon which is described is that if we change from the tube nutrition to breastfeeding nutrition, then we frequently see a less less weight gain at the end when the babies are 35, 36 weeks. But what we have noticed when we modified our discharge regimen, and as soon as the baby gets enough, which means in terms of fluid, breast milk, then we discharge the baby. And as soon as the baby is at home, they really go back to the initial percentile. So which means we have to have here more variable. So we don't need to stick at this percentile grow as one precondition for discharge.
Perfect, thank you. How did you gather information, and how often did you meet to revise your plans? Were there any financial or gifts to promote or buy-in with the nurses?
Again, I'm not sure whether the challenge is how do you motivate the nurses, when I understand correctly the question. At first, our revision cycle of all documents is 2 years, but we have these meetings once a year where we have the new staff members and the old staff members, nurses, but also physicians and other people involved, where we reflect our current quality and discuss what we can do better. So this is one part of also maintaining the quality, but it's also one part of engaging the nurses and the all staff members. With respect to motivation, they do not get really personal benefits by doing good quality of care. We work by creating a common sense of work, so to say. And the work in neonatology is one of the most meaningful and sensible work I can imagine. And I think this is the best motivation if we achieve to have the spirit in the unit that we want to have the best practice. And you know, I've got 4 kids, and I always tell the people, the parents, they give us their kids, which is the most valuable subject they have, and they trust in us. And we have the ethical responsibility to provide our best care. And at least this was motivation enough in our unit.
Understood. Thank you so much for that. Another person, thank you for your great presentation, which is so inspiring for any hospital wanting to develop the quality of care. Which first step would you recommend to your peers or clinical director for starting working at quality improvement?
The first step is watching and analyzing and talking. As mentioned, the people are highly motivated, but a lot of people working in the NICU, they are frustrated by this bunch of barriers, limited resources, and we have to collect all these opinions. And then, and this is the most important step, I think, you have to create a common spirit and a common goal. And this is actually really the first thing we did, that we collected all the people together and we said, okay, what are our vision? How do we want to have a preterm baby and its family handle, because you can discuss. There is a theory of negotiation. If you negotiate, the major pitfall you can do is that you negotiate the positions, but you do not negotiate the goals. And if you go immediately into positions, yeah, you didn't do this and I want to do that, that's very difficult. So which means you have to agree on the common goal, on the vision, and then you discuss how to implement it best. And then you can discuss, you're right with this position, but let's adjust. So which means the first step is watching, analyzing, and creating one common goal.
Perfect, thank you. In my area, there are many patients that come in with no intention to breastfeed. What do you believe is the best way to address a disinterest in breastfeeding, especially when a language barrier is present?
Yeah, that's one of the, thank you for this very challenging question. I think we really need to be very precise in our statements and very clear. And I have provided you with the example that our patients need to sign really a piece of paper that they want to have formula nutrition. And in this paper is highlighted that if the baby is fed with formula, an increased risk of necrotizing enterocolitis, and that more babies die if they're fed with formula. I'm not sure whether you can adopt it to every country, but I think what we can be adopted is that we need to be more precise and clear in our messages. We tend to be very polite and very descriptive, but we really need to tell them and highlight like smoking is bad, smoking will kill you. And some people still smoke, you can't change it, you have to accept it, and we cannot, it's just the way it is. And some people drink alcohol too much, but at least we need to have a clear message. And we have to provide, of course, informational material in the adequate language, but with clear messages, with clear statements, what is, in our eyes, evidence-based medicine for the patient.
Wonderful. How did you involve midwives and your colleagues from the maternity to support the preterm moms from the early beginning?
Yeah, it was the same with the overall stuff. We tried to listen to them from the very beginning, engage them from the beginning, and made them team members from the very beginning. It's very, very important that they feel integrated from the very beginning. And we do see that if two new team members from midwives come from externally, that we start from the beginning. But it's worth, and you have to integrate the midwives into the overall concept. We have to bridge the gap between prenatal care and postnatal care. And this is by talking to each other and make clear that if we want to have the best care, then it's one multidisciplinary team from the prenatal period until discharge.
Perfect. You're getting many compliments coming in and many thank yous about your presentation, by the way. And they're quite amazed at how you include everybody from this cleaning staff all the way up. One final question, I think, is all we have time for. How did you get the building service involved, the cleaning personnel? How did you get them involved?
That's what actually one of the easiest part, because sometimes these team members, they seem to be neglected from other team members. And I learned actually by Silke Mader, who's co-founder of EFCNI, and perhaps somebody, she's now with the WHO and one of the most global networks. And I heard a story of a mother having had a preterm born infant, and the mother just delivered the baby, and then the cleaning lady was cleaning in her room, and then she said, "Oh, what do you have?" And she said, "Oh, I just had a preemie." And then the cleaning lady said, "Oh, these preemies, they all will be handicapped. I don't know what they're doing in this unit over there." And the mother was completely distracted and completely unsure. And I remember this story, and it made me clear that we need to involve the cleaning stuff. And if you just go to the responsible person of the cleaning stuff and say, okay, actually you do cleaning, but you are important as multiplier for the families, and you are actually part of a team which takes care about quality of care, and then they were actually much easier to integrate in a team and motivate to get motivated than others. And they were also told about the importance of breast milk. They had the same information like nurses, because this is a message everyone can understand, that human milk is the best.
Wonderful. And again, you're getting so many compliments. I believe that's all we have for questions. So thank you so much, Professor Keller. And thank you
You're welcome.
everyone for, oh, sorry. And thank you everyone for attending today's webinar, Taking Ownership Strategies to Bring Evidence into Clinical Practice. Once you leave today's webinar, you'll receive a survey on the presentation, and we would appreciate if you would complete that and provide your feedback. You will also receive a follow-up email within 3 days with a link to the survey if you are unable to complete it now. On behalf of Medela Education and our presenters, thank you so much for joining us today, and have a great rest of your afternoon. Thank you again, Professor.